to stand here at the start of a journey, not only to look at how we transform how we think about colorectal diseases in Ghana, but also to make an impact in terms of policy making, education, advocacy, and how to even engage with the community. We know that colorectal diseases are very common in the country, affecting thousands and millions of people. But unfortunately, in Ghana, discussions around colorectal disease is shrouded in silence for how it is, in stigma, and unfortunately is totally overshadowed by other diseases of public health concern. Today, we are here to change the narrative. It changes today. This workshop is a call
to invite the CEO of Komfanochi Teaching Hospital, Professor Chiadai Mensah, to address us.
Good morning, distinguished ladies and gentlemen. I want to apologize profusely for turning up late. It is not my style. Unfortunately, there was a miscommunication. And so I went to the eye center at 8 o'clock, hoping and waiting to see at least Dr. Agbedinu. Unfortunately, at some point when I was asked what I was doing, and I told them that, oh, well, I'm waiting for the participants to the colorectal workshop. That was when I was told that, no, it's at Mickling and not at the eye center. So I'm sorry for holding you up. On behalf of Komfanochi Teaching Hospital, I extend a warm welcome to all of you and offer my sincere congratulations to the organizers, speakers, and participants who have made this moment possible. Your dedication to advancing colorectal health in our nation is both timely and deeply commendable. And I'm very happy to see the Vice Rector of the Ghana College of Physicians and Surgeons, Professor Lawson. Welcome, sir. Colorectal diseases ranging from common benign conditions like hemorrhoids and anal fistulae to life-threatening illnesses such as colorectal cancer represent a significant yet often overlooked public health burden in Ghana. These conditions affect thousands of individuals across all walks of life. Yet too many continue to suffer in silence due to limited public awareness, late diagnosis, and restricted access to specialized care. As one of Ghana's leading teaching hospitals, Komfanochi Teaching Hospital stands at the forefront of tackling these challenges. We embrace our mandate to lead not just in clinical service, but in education, research, and advocacy. And we see this not only as responsibility, but as a moral imperative. First, let us talk about awareness. Many patients with colorectal disease delay seeking care due to stigma, fear, or a simple lack of understanding. We must change this narrative. Public education is critical so that Ghanaians can recognize the signs and symptoms early and feel empowered to seek help without shame. We at Confanoche are committed to using our platforms within the hospital and the community to increase public knowledge and reduce the stigma surrounding colorectal conditions. Second, we must strengthen early diagnosis and referral systems. Conditions like colorectal cancer, diverticular disease, and inflammatory bowel disease can be effectively treated when detected early. We are actively expanding our endoscopy, imaging, and pathology services, improving referral pathways, and training providers to ensure no opportunity for early detection is missed. Third, we are deepening our commitment to comprehensive and multidisciplinary care. Managing colorectal disease often requires a team-based approach, including surgeons, physicians, nurses, nutritionists, and even mental health professionals. We are investing in both infrastructure and training to ensure that we can offer holistic patient-centered care from diagnosis through recovery and beyond. Fourth, we must build local evidence. Despite its growing burden, colorectal disease remains under-researched and under-documented in Ghana. As a teaching and research institution, Confanoche is committed to generating local data that reflects our unique context. This data is essential, not just for improving clinical care, but for shaping national health policy that is responsive, inclusive, and effective. We welcome opportunities to collaborate with academic institutions, ministries, and internal partners to expand the research base and drive innovation in colorectal care. And finally, we must work together. No single institution or sector can address these challenges alone. We need strong partnerships with the Ministry of Health, the Ghana College of Physicians and Surgeons, our fellow hospitals, non-governmental organizations, global collaborators, and most importantly, our communities. This workshop marks an important turning point. It brings together expertise, passion, and purpose. Let us seize this opportunity not only to share knowledge, but to build networks, develop best practices, and chart a clear path forward for colorectal health in Ghana. Let us envision a future where colorectal diseases are no longer hidden or stigmatized. Patients are diagnosed early and treated with dignity. Health professionals are equipped to lead the work for generations to come. On behalf of Confanoche Teaching Hospital, I reaffirm our commitment to being part of this future. Together, we can transform the way colorectal care is delivered and ensure that every Ghanaian, regardless of geography or income, has access to the care they deserve. Thank you very much for your attention, for your commitment, and for your presence here today. God bless us all.
Thank you very much, Prof. I picked a few keywords: early detection, networking, changing, our outlook and everything about colorectal diseases. And I'm happy that you are all here and becoming part of that change. And I hope that as we go through the rest of the day, you'd all pick nuggets that by the time you walk out of this door and out of this premise, you'd become an ambassador for changing how we manage colorectal diseases in your hospitals, in your communities, and the country at large. Next to address us would be the Vice Rector of the Ghana College of Physicians and Surgeons in the person of Professor Henry Lawson. Please, shall we welcome him with a round of applause?
Good morning, everybody. So on behalf of the Rector of the College, Professor Richard Adanu, I represent him at this time to give a short, I'm told it's a keynote address, but it's not very long, so don't worry. Typically, we should do protocols. I'm not very good at it, so there's this word people say, I'm standing on the existing protocol. But the CEO didn't help me. He didn't bring any protocol. So maybe I'll say a few things towards that. So program chair is the regional director here. I can't see him. Or does he have a rep? He is. All right. So program chair, regional director of health for Ghana Health Service, CEO Confanoshi Teaching Hospital, distinguished conference speakers, training faculty from the USA and Canada, all other healthcare practitioners present, ladies and gentlemen. The Ghana College of Physicians and Surgeons was established in 2003, and it is a national body responsible for residency training and specialist certification. The college is an agency of the Ministry of Health and structured under 2 divisions, physicians and surgeons, and 17 different faculties. As at December 2023, the college has graduated 1,027 specialists in the division of surgery, and 169 of these specialists have proceeded to become senior specialists in various subspecialties. The number of specialties on the Medical and Dental Council Specialist Register is 1,312. You see a huge deficit there because what I'm mentioning is just for surgeons. When we add the physicians to it, it's way over 2,000. Yet the Medical and Dental Council has registered 1,300. So the number of experts in each discipline produced by the college keeps rising. However, this increase is being outstripped by the population growth, leaving our specialist to patient population ratios far below the WHO expectations. Colorectal surgery as a subspecialty is relatively new in Ghana, leaving the country with few surgeons who have specialized in colon and rectal management. The college is proud of its partnership with the University of Michigan, University of Utah, University of Arkansas, and the University of Minnesota to expand training in colorectal surgery in Ghana. The college is represented in the collaboration by the Faculty of Surgery and Subspecialties. The college is pleased with the strides the team has made so far, from a virtual platform of several meetings to develop a curriculum, to training and graduating the first post-fellowship resident, and currently having 2 post-fellowship trainees in the program. The college is also proud to announce that very soon, one of the graduates of the program will be stationed at the Eastern Regional Hospital, which is outside the teaching hospitals. This will go a long way to start the journey of addressing the screening and management of colorectal cases in the periphery. In order to spark interest from general surgeons in other parts of Ghana to support the effort to expand care to the regions and alleviate the strain on the 2 main teaching hospitals, Kolibu and Konfanochi, the college would like to encourage our trainees to keep interacting and talking with their mentors and colleagues. The college is pleased to observe the active involvement of nurses in this drive to increase awareness on colorectal conditions. Their participation reflects a collaborative approach to healthcare that is essential for delivering comprehensive and patient-centered care. It is a testament to the dedication of our colorectal surgeons who do not only excel in their surgical expertise, but also demonstrate a strong commitment to interdisciplinary learning and knowledge sharing. By equipping nurses with specialized insights and practical knowledge, they are fostering a more informed and empowered nursing team. This collaboration ultimately enhances the quality of patient management, promotes continuity of care, strengthens outcomes across the entire treatment journey. It is through such initiatives that we continue to build a cohesive and skilled health workforce united in the mission to provide the highest standards of care. The college appreciates faculty from the US and Canada for the resources they provide through supplies to equip our facilities and to ease the work of the trainees. We are grateful to the CEOs of teaching hospitals who have allowed their facilities and staff to be used for this training. We look forward to a future where each regional hospital will have at least 2 colorectal surgeons and a good number of supporting health professionals to bring enhanced healthcare to the community. For the benefit of our entire nation, the college reaffirms its ongoing dedication to developing specialized expertise in medicine and surgery. And before I leave, I just want to share my personal encounter with colorectal conditions. It really hit us hard in my family. My mother died from colorectal cancer. Then her younger brother, immediately following her, also died from colorectal cancer. So in my house, we and the colon, we are not friends, but we are friends. Because if you don't respect him, he will disrespect you. So we are always going in for the tubes to go in and out and make sure that, so before I end, I would like to say that I finally implore everyone in attendance, especially the doctors, to take a moment to get their colons examined. Thank you.
Thank you very much, Prof. I think you couldn't have ended on a better note. Colorectal conditions are closer than you think. And so, I mean, the earlier we all get involved, the better, not just for us, but for our communities. And to the residents, like you said, please speak to your mentors. We are not doing little drops of water make a mighty ocean. We've started big drops. And so make sure you catch one of those big drops, hop on to the training program, and you never know. All those who are going anywhere else besides general surgery, please, this is directed at you. Next to address us is the Regional Director of Health in the person of Dr. Fred Adumaku-Boateng. Please, shall we welcome him to a round of applause?
Good morning. Program Chair, CEO Konfanoche Teaching Hospital, Prof. Dr. Ochiada Mensah. Vice Rector, Ghana College of Physicians and Surgeons, Prof. Henry Lawson. Colleagues from Canada and my staff, good morning. Anytime I have the opportunity to interact with my colleagues from Teaching Hospital and Regional Hospital, I always share this story. Remember when we started, finished my house job and I was working at Konfanoche. Anytime I was seated at the OPD and then we had a case referred from Centreso Hospital. Look, you could have a case of simple diarrhea referred from Centreso Hospital to Konfanoche. And then as medical officers, we will start insulting them. Don't we have doctors at Centreso Hospital? Don't we have doctors at Menchia Hospital? Why are they referring so basic cases to us? That is one of them. Until I had a shock of my life and I was posted to Centreso Hospital. Colleagues, when I got to Centreso Hospital, there was only 4 beds for admission. Only 4 beds that you could admit patients on. So whether they are simple malaria cases that you have to admit, there was no bed that you could admit the case. You had to refer. And not only that, whilst I was seated at Konfanoche, we had an idea that, look, it's only medical doctors, specialists that were seeing patients. I'm not trying to say this to downgrade anybody. And I'm referring to this is about 2004, about 21 years ago. So I got Centreso Hospital, and there was only one doctor there. All the rest were physician assistants. And I can't remember those of us who are, Ujam, and them say, so why do we have physician assistants at this district hospital? Colleagues, when we come here, if you look at Ashanti region, we have 43 districts, and all of us are supposed to have district hospital. If you look at the basis of or the unit of care that we deliver is the chief's compound, you come to health center and you come to the district hospital. if you look at the distribution of staff within Ashanti region, about 80 to 90% of all medical doctors are in Komfanoche. And therefore, when we are talking about disease prevention, we always have this discussion that, look, who is the best person to see a case and make a lot of impact? Is it the expert person who can really see a case and then look and say, look, this case is supposed to go here, that case is supposed, or you leave people with low expertise at these areas where, for want of better words, let's say they will mismanage these cases before they refer to Komfanoche. And so when we have this opportunity and then we bring other people on board, for us, it's very insightful and very important because, look, majority of our cases are seen by the district hospital. I don't want to give the statistics over here. Most of our hospitals, yesterday we had a chat with Tepa Hospital, and basically they have only 2 doctors per hospital, and it's run across all. And so when we are seated in other, and I would say, if you look at our regional hospital, where we are supposed to provide different levels of care, which is secondary, we are also lacking in terms of our ability to do that. And normally, we always have this saying that what is not in the mind, the eye will never see. And so when we are here and then we are going to be exposed to this more important topic, colorectal cancer management, and we as Ghana Health Service, seeing majority of cases, you are going to target us. I believe that's the right way forward. And when we do that, because we are talking about quality of care, if we come to the primary health care, most of the time that we do, we lack especially certain diagnostics and investigation capacity. All of them are in the tertiary and secondary hospital. And then it's easy for us to see the cases and miss them. So once we come here, and we'll be able to empower and give us the capacity to be able to pick these cases, I believe that we are not going to see the cases at the terminal cases where we refer to Komfanoche, where quality of life is very low, where we can't do much. And we are ready to collaborate with this. I also enthralled when I got this message from Kwabena, and I asked, are we going to pay? He said, no, we are not going to pay. And I said, we need more people to come. So we wanted more people to come so that they can come and learn these basics. And we don't have to wait. We are praying that, Prof, we won't have anybody presenting with these cases late in our facilities. How can we do that? How can we strengthen the referral system? How can we build our capacity so that we can even manage some cases that are not supposed to come in terms of the terminal care? So we are here and we are in full support of whatever is going to. Just let us know what is expected of us. And then the basic thing that you want us to know, we are really happy to know, to learn. We will say that the numbers here are not enough. How do we make sure that those of us who are going to benefit from this cascade it down? How do we make sure that the things that you have taught us, we are able to do it in the context of where we are coming from? For me, that is important. Most of the time, we have an event, and the other things that will make whatever we have decided to do very fruitful and important is left behind. I believe that let's factor in supportive supervision, let's factor in monitoring, and tie it with all these so that at the end of the day, the things that we are looking for will be able to do. I will employ all the program managers and all of us that please make sure you come to our facilities, look at what we have, look at what we can do, and see how we can support in addressing this issue. At my age, I believe I'm a risk. I'm a risk in terms of age and sex. I will take your advice and make sure that I have my examination this year. On this note, you are welcome to this program. Thank you.
Thank you very much, Dr. Admakbuati. As a student, one of the things my professors used to say was, what you do not know, you would not see, or you would not be able to identify it. And our regional minister has alluded to a lot about early detection, and which means we need that knowledge to know what to look for. And that's actually the theme for today, advancing knowledge. And so starting, or as we move on from now, there's going to be a lot of knowledge sharing. And I implore you all to open your eyes, open your ears, let's all engage and learn something new. To set that knowledge trail going is Professor Antoinette Bediakuboan. She's the head of the colorectal surgery unit in Kolebu Teaching Hospital and also a professor of surgery with the University of Ghana Medical School. Shall we put our hands together for her as she comes up to teach us about rectal prolapse, rectal prolapses? Thank you very much for calling.
So good morning. I'm not sure I'm supposed to do protocols when it has to do with presentation. So I'll just dive into the presentation. Where do I point this to? So I was supposed to come after Prof. Dakubu when he talks about benign colorectal diseases. So this might be too much to start with. And for those who are not conversant with colorectal diseases, please bear with me for the pictures that you see. I don't know where to point it to. Yeah. Yeah. Okay. Okay. So I'm supposed to talk about rectal prolapse. Rectal prolapse is a full thickness circumferential protrusion of the rectum through the anus. It's not a relatively common disease, but they say about 0.5% of the population would present with rectal prolapse. In Kolebu, we roughly see between 6 cases a year to 17 cases a year. So roughly we are seeing between like 10 cases in a year. Um, Can someone help me with this? The pointer has to go all the way. I think the We can skip and go here. This one talks about this. Sorry. So this slide is talking about the factors, the risk factors for developing rectal prolapse. So you can pinpoint exactly what is what we would associate with what is the cause of rectal prolapse. I will associate it with people who have chronic constipation, people who have obstetric related pelvic floor dysfunction, high parity, chronic straining on defecation, neurological illnesses, connective tissue disorders, abnormal fixation of the rectum with a mobile mesorectum. Next. Next. Isinam said anything can happen. it can tell you whether this is purely a rectal intussusception or a rectal prolapse. A rectal intussusception would have the middle part of the rectum intussuscepting into the distal rectum without necessarily coming out of the anus. And treatment for that is obviously different. You can approach it most of the time from the perineal region, but you have to approach it from the abdomen. So the difficography can be done either by using a fluoroscopy. Elsewhere, they have available, obviously you have fluoroscopy machines here, so we can do a difficography. It's just a matter of educating our radiologists to help us out. Our radiologist in Korle Bu has done one difficography for us. They struggled a bit. They put a wooden chair and the patient sat on it to mimic the patient moving the bowel. And then they took fluoroscopic pictures of the process. And we could, for that patient, tell that the patient had an erectile intussusception and not a total rectal prolapse. Then you can do a digital MRI difficography. That's pretty uncomfortable because the patient is lying in the MRI machine and the patient has to mimic just lying down and then tell the patient to act as if they are moving their bowel, and then you take the pictures. The good thing about difficography is that it can tell you about other things apart from just the rectal prolapse. If a patient has a rectal cell pushing into the vagina, or the patient has a cystocele, it's able to tell you about that one. And it tells you about the structure of the rest of the pelvic floor more in the MRI difficography. You can also do an anal manometry, which, because a repeated stretching of the anal sphincter, would have a reduced sphincter squeeze pressures. Obviously, the many times that the rectum pulls out of the anus, the anal sphincter would be more lax. It's good to do an anal manometry so that you know the baseline, so that after, when the patient keeps on having incontinence, you know where you started from, you know how to deal with a physiotherapist and how to manage those patients. The treatment, we see that rectal prolapse is very difficult to treat. It has over 100 procedures that have been described. That shows how difficult it is. There's no one procedure that we can say this is what you do for rectal prolapse. But surgery has the potential of being curative for full thickness rectal prolapse. We have two approaches, an abdominal approach and then a perineal approach to treating rectal prolapse. And there was a study that was done some years back that said that whether it's an abdominal approach or a perineal approach, the outcomes are comparable. But most of the time elsewhere the very fit patients would have the abdominal approach, and those who are unwell or look very frail, they would opt for them to have a perineal approach. I remember one patient who had huge ascites, who presented with rectal prolapse. Eventually, she was convinced not to have the surgery. But a year later, she came back and had a perineal approach for her surgery. Abdominal approach means that the patient will be under general anesthesia. It's a matter of whether you are doing the surgery open or laparoscopically. There are procedures where we would say that you are either doing a suture rectopexy or a mesh rectopexy. You would decide whether you're going to resect or you're not going to resect. Abdominal approach also, you'd have to weigh in the surgeon's experience in doing whatever procedure that's going to be done, and the patient's habitus. Obviously, a very big patient, you would decide on, you'd have to weigh in the type of procedure you're going to do and the general health of the patient. For the abdominal approach, there is anterior resection that can be done. I don't remember the last time anterior resection was done in Korle Bu, but like 10 years ago, they used to do a lot of anterior resections for patients with rectal prolapse. So anterior resection as surgeons, we remember is the resection of the rectum, proximal rectum, proximal, I wouldn't want to put proximal there, but proximal rectum, and then doing a colorectal anastomosis. It's virtually, then we have the rectopexy. And whether you do it open or not, the procedure is virtually the same. Obviously, the laparoscopic procedure gives you more visibility than doing an open procedure. And it is mobilizing the rectum, and then you would suture the mesentery of the lateral wall of the rectum to the sacral promontory so that it sort of fixes the rectum onto that bone so that it doesn't intercept through the anus. Then there's a mesh rectopexy. The mesh rectopexy, you are either putting the mesh on the anterior surface of the rectum and then pulling it up and then fixing it on the sacral promontory, or you are putting the mesh, you are wrapping the mesh around completely and then fixing it to the back there, or you're putting a mesh partially around and then fixing it at the back. Next picture. Then the other procedure is considering, apart from just fixing as a rectopexy, you also have to resect a section of the sigmoid with it, and that sort of reduces the patient's chances of still having constipation, because then you have a lot of redundant sigmoid or a lot of redundant colon in the left in the abdomen. As I already said, perineal approach is most suited for, is best. We've just finished the abdominal approach. So sorry. So the next is the perineal approach. The perineal approach we use for patients who are typically unfit, even though for us in our unit, we use the perineal approach for virtually everyone. It can be performed without general anesthesia. So that's the good thing, under spinal anesthesia. The procedures are either you're doing a perineal rectal sigmoidectomy, which is commonly known as the Altemeyer's procedure, adding a levatoplasty to it, and then doing a Delomis or doing a TH operation. So the common one is the TH operation. The TH operation is supposed to be a temporary procedure, or for people who are we don't think they can withstand any form of surgical treatment. Then you can do the TH operation for them. It's virtually encircling the anus with silicone or dacron or nylon. So the common thing that we have used in our hospital is to use nylon. You encircle it, and we just say you go twice around the anus, and then you tighten it. The essence is that then the rectum does not collapse through the anus. Again, you can do that under spinal. Some people have advocated that it can be done under local anesthesia. The recurrence rate is very high. And let's remember that it's a temporary procedure. So the pictures show the one on the right, the fair bottom, is a patient, a 60-something-year-old patient who had a TH put in 3 years prior to presenting to us. And she had been having recurrent abscesses because the rectum is trying to push out, and there's something preventing it from pushing out. So sort of developed some sort of fistula that was kept on discharging every time. And then the second one, the black bottom, is a patient who just presented to us yesterday, who also had a TH procedure done 2 years ago. And this is a young man in his 30s, had a TH done 2 years ago. And he also has started having the discharge coming from that point that we see there. The next one. So TH is a temporary procedure. After that, you can move the patient onto a facility that can do it for them. Then the perineal rectal sigmoidectomy, that's the Alzheimer's. The aim is to resect the redundant rectum and then anastomosis to the anus so that the prolapsing would reduce for the patient. So this is the rectum of someone that had prolapsed out. It's virtually making an incision away from the dentate line, because if you go into the dentate line, the patient is going to have pain a lot of time because you have the pain fibers in the dentate line. So away from the dentate line, you make an incision around, and then you dissect down to, you dissect down until you are able to enter the peritoneum, and then you would clamp ligate all the mesorectum and free the distal rectum of all the mesorectum, and then you would resect that redundant rectum that sort of slips out of the anus, and then do a coloanal anastomosis after that. So that's the anastomosis. A lot of times, by the time you finish, the rectum would have pushed in, and in a week or two, the patient would have a nice bottom. The things you have to look out for is the fact that they can bleed a lot. Anesthetists are always like, what are they coming to do? Alzheimer's, they're a bit on their toes because the patient can bleed with Alzheimer's. And then you can do a levatoplasty to help with sphincter control. And for all those that do a levatoplasty, for studies have shown that adding a levatoplasty to an Alzheimer's increases or reduces the risk of incontinence after surgery. The patient will need physiotherapy after that. Next. Then we have the DeLorme's that can be done. The DeLorme's it's a modification of the Alzheimer's, but you're not resecting any bowel. You just resect it's more of cleaving the mucosa off the rectal wall and resecting the mucosa off the rectal wall and anastomosing the proximal part of the rectum to the distal part. But before then, you would plicate the muscle of that rectum that you have denuded of the mucosa. Next. So this is virtually a patient with, looks like that's the length of the rectum that prolapses, but by the time you dissect everything, you can have the next picture. You can have a long rectum that has actually been dissected. And then after, you would cut off that mucosa and then anastomose the new site to the anus. So post-surgery, patients, you should have to think about problems that the patients would have. The patients would have to move to the bathroom several times. We reviewed a patient yesterday who said, all I think about is the fact that I have to go to the bathroom a lot of times after an Alzheimer's procedure, because the patient no longer has the roomy rectum that was storing stools for them, and after they would have something. And then there's the risk of having bleeding if you don't secure the bleeding during surgery, and then tenesmus, and then pain on defecation. Incontinence can improve with physiotherapy. Anal stricture is also a complication that you can think about. And then recurrence, and the recurrence can be full thickness or mucosal prolapse. So a lot of our patients would have, well, not a lot. Looking back, the patients that have had some sort of recurrence, some have had mucosal prolapse. And then others, one has had a full thickness prolapse. As to what to do when the patient comes to the recurrence, is a difficult one. We had one patient, we did an Alzheimer's for and came back with a recurrence and went to do a DeLorme's for, and we are keeping our fingers and toes crossed that she doesn't come back. And another patient had a DeLorme's and came back with a prolapse, a recurrence, and we went and did an Alzheimer's. So we'll wait and see. So in conclusion, rectal prolapse is a pelvic floor disorder. There are many variations in the surgical management that can be given to patients. Abdominal approach is recommended in most fit patients. Perineal approach is left for patients who are unable to undergo an abdominal surgery. Minimally invasive method is the way to go now. And let's remember that there's no single most ideal surgical repair for the patients with rectal prolapse. So I think that ends it. Thank you.
Thank you very much, Prof. Bowen. And apologies and to all of us for the hitches, but that's the reality of life, isn't it? Things just never turn out the way you plan them all the time. Please, we'll take just 2 questions, if there are any questions. 2 questions for Prof. Bowen before she sits. Yes.
Thank you very much, Prof. Bohan, for your presentation. I'm Kingsley from Holy Family Hospital, Techiman. I think one important differential diagnosis when it comes to rectal prolapse, our practice is intussusception, ileocolic. We've had a few cases of ileocolic intussusception presenting as prolapse, mass protruding through the anus. I want to find out. I think trying to make a diagnosis is very, very important, because those particular cases were thought to be just a rectal prolapse. And also, if you're at the district hospital, you are supposed to manage everything. We are confronted with rectal prolapse in children. And I want to find out what's the current approach, children presenting to you with rectal prolapse. Thank you.
So the pediatric surgeon would tell us that children are not miniature adults, so I won't venture into children with rectal prolapse. The pediatric surgeons take care of children with rectal prolapse. I'm not sure about them doing surgeries for them at that age, so I would veer away from children with rectal prolapse. When you talk about the ileocolic intussusception, well, there's been you can have coloanal intussusception. There was a patient who presented that were called that the patient had a rectal prolapse, and you are able to insinuate your finger around, and it goes very deep. So it wasn't just rectum that was prolapsing. So such patients, there's no way you're doing any perineal approach for such patients with coloanal intussusception. As to the ileum coming that far, I haven't seen one with the ileum coming all the way out into the anus, but colon coming into the anus, yes. So it's about doing a laparotomy, the emergency situation, doing a laparotomy and reducing the intussusception, and then seeing if you can, if there's no gangrene, hooray, or if ischemia, hooray. But if there is, then you'd have to resect whichever gangrene that has occurred. But I talked about rectal intussusception. And it's virtually the same thing, just that for rectal intussusception, because the rectum may be fixed there, maybe everything will not come out, but it's a difficography that can help you say that the person has a rectal intussusception and not just the usual rectal prolapse that we see.
Thank you very much, Prof. I wanted to find out that does Kegel exercises of the pelvic floor muscle, does it have a role in the management? Because you mentioned that weakness of the pelvic floor is central in the pathogenesis. Thank you.
Yes. Exercises of the pelvic floor muscles does play a role. The physiotherapists have a way of doing that. Well, in more advanced countries, they have all this thing about biofeedback things with helping with improving pelvic floor muscles. But as I said, full thickness rectal prolapse surgery is the mainstay. No matter, you can start with those to see if, but it's not going to stop the prolapsing from coming out. You said 2 questions.
Yes, to assist with the question that Kingsley asked, I don't think Techima is in the malnutrition area, but I will not be surprised if these children you are referring to have some amount of malnutrition. You see, the definition of rectal prolapse is full thickness prolapse, as opposed to mucosal prolapse, which is not full thickness. So first, the clinician should be able to tell which one we're dealing with. In children, you tend to have more mucosal prolapse than true rectal prolapse, and it's more nutrition, infection with nematodes, worms, and other causes. So the PSA actually don't operate on them. They will look for more nutrition arthritis and treat. Then the mucosal prolapse disappears. So the point I'm making to you is that when you go back and these things come, try to see, is it a real rectal prolapse or they are mucosal prolapse? And if they are, the future of the patients and infections, and you may not need to operate on some of them. Thank you very much.
Thank you very much. Contribution. Okay.
Yes, good morning. First, thanks a lot to smart presentation. Okay, Dr. Ramirez from Tamale Teaching Hospital, Northern Region, colorectal surgeon. So I think the cornerstone of the, not only about the rectal prolapse, the pelvic floor diseases is the proper investigation of the pelvic floor just to determine the cause. Because, for example, I have missed here the neurophysiological studies, electromyography, for example, to find out if any enlargement or neuritis of the pudendal nerve, as C.S. Martin said. So this is one thing. Second, don't be in a hurry, never for surgical approach. So I think that it's very important to train this pelvic floor before surgical approach, right? At least 1-2 months doing Kegel exercises or in some other environments
The pelvic floor is somatic, but it's in continuous tonic contraction, involuntarily. And it's this reflex that maintains it. When we inhibit this reflex, then the pelvic floor relaxes, the anal sphincter is open, and we can void. We can read more about it and waste time. And the components of this reflex are the stress receptors in the rectum, pelvic floor, the minor plexus in the rectum, the transition nerves, and the pudendal nerve. These are able to maintain the rectoanal inhibitory reflex that gives us continence and keeps the pelvic floor tight. Move on. Incontinence is a big problem, and sometimes it can be worse with air than solid. So we need to know what incontinence is. I can make a whole presentation on this, but you need to know it. Air incontinence can be more troubling than a solid incontinence, and we need to fix that. Almighty hemorrhoids now. Hemorrhoids are normal tissues found in the anus of all mammals. But because we human beings have assumed the erect posture and we squat to defecate, we tend to develop disease in it more than the other animals. And so a veterinarian may have difficulty diagnosing a complicated hemorrhoids in a cow or a goat or a dog because it's not a diagnosis they think about at all. So hemorrhoids basically are made up of sinusoidal vessels. And these sinusoidal vessels don't have media. They don't have muscle. So their support is the fibroalveolar tissue in the connective tissue elements. And these fibroelastic connective tissue form condensations that are the hemorrhoidal ligaments that hold the tissue onto the internal anal sphincter. Primary hemorrhoids are located at 3 o'clock, 11 o'clock, 11, as we are told some variations, but basically that is the anatomy. And we have tiny hemorrhoidal tissues between these ones referred to as secondary hemorrhoids. Anytime we're having discussions on hemorrhoids, our attention is more in the internal hemorrhoids than the external hemorrhoids because the external hemorrhoids, the main problem we have with them is thrombus formation, a clot formation, severe pain that if you can go and take off, the patient has no problem. The sinusoids, as I mentioned, have valves at the arteriolar ends and the venular ends. And these valves control the inflow and outflow of blood. So when we are going to move our bowel, the vessels fill with blood to cushion the anus against the force of transmission of feces, as described by Thompson in 1975, where he referred to them as the anal cushions. After defecation, they empty the blood, collapse, help see the anal canal to maintain continence. But what happens is, move on, over time, the fibroelastic connective tissue lose their elasticity. They lose their tone, and the valves become incompetent. So the sinuses are permanently filled with blood. And when that happens, in between defecation, the patient can have problems. That's right. So the pathology of hemorrhoids, as I've said, are the weakness in the fibroelastic connective tissue, elongation and dilatation of the sinusoids, incompetence of the valves. The sinusoids are permanently filled with blood. You have sinusitis, you have proctitis, and you have weakened sinusoidal walls, which can rupture when the valsalva maneuver for defecation is applied. Let's make progress. We know the stages of hemorrhoids are based on this degree of weakness of the fibroelastic connective tissue. So when the degree is less, the hemorrhoid doesn't prolapse, stage 1. When it has moved forward, there's prolapse by spontaneous recoil, is stage 2. When there is prolapse and there's no spontaneous recoil, but it will stay with molar reduction, stage 3. And when you have proxidentia, that is stage 4. And here we're talking of uncomplicated hemorrhoids. Prolapse thrombosed hemorrhoids are an entity by itself. So the symptoms of hemorrhoids are basically bleeding per rectum at normal defecation. Prolapse of a lung through the anus at defecation. Pruritus ani, feeling of warmth in the anus, anal discharge. Here we have to investigate. We see hemorrhoids, we don't feel hemorrhoids. You must see hemorrhoids, push out or in proctoscopy, and we need to do a colonoscopy. Since I moved into private practice, I've seen the importance I saw it, but now more important because of people come with colonoscopy reports. I say, yes, it was done by my colleague 6 months ago, so it's free. I go to do a hemorrhage, and the following week, there is bleeding. I have to go into colonoscopy on anesthesia because of the machines there. Then I see they have missed a tumor, 10 centimeters for anal veg. They have missed a tumor in the sigmoid. So colonoscopy for the colorectal surgeon, for God's sake, try to repeat it, even if that's done with your colleague you trust him. Try to repeat it. Complication of hemorrhage, bleeding, anemia, thrombosis, infection, incarceration, gangrene, and ulceration. Move on. And the treatment is like this. This is a sketch. So there are many approaches to treat hemorrhoids. The non-surgical approach, the surgical approaches, the minimally invasive approaches, the excisional approaches. Move on. So basically, in a summary, we have the open Milligan-Morgan, the closed Parks Ferguson, and what the circumferential excision, which is the Whitehead. Then we have the use of special devices, minimally invasive procedures, hemolytic artery ligation, use of ligature, laser, cryotherapy, stapler, banding, everything. They are all available. But you choose the appropriate person. I think cryotherapy is one of the most useless things that we have now. Move on. Anal, perianal, and perineal abscesses. These are collections of pus in the perineum. And until I settled on colorectal surgery, as I never knew we have so many spaces there that abscesses can collect. And the spaces include the submucosal space, the perianal space, intersphincteric space, ischiorectal space, superficial postanal space, deep postanal space, supralevator, and retrorectal spaces. We need to know this as trainees of colorectal surgery, and we need to diagnose them properly before we treat. So looking at the sagittal section and then the coronal section, they are defined. I don't have a marker, a pointer. But what I'm more interested in is the posterior ones. From top to bottom, the retrorectal space, the retrosacral space, the supralevator space, the deep perianal space, the perianal space. I think we need to know this properly. And if you have challenges, you need to do an endoanal ultrasound or endorectal ultrasound to define them properly and treat them appropriately. If not, you keep treating and the abscess will keep on recurring or persisting. So the investigation is perineal or endoluminal ultrasound, a CT scan if it is difficult, or MRI if you have the facilities and the money to do that. And treatment is effective drainage, antibiotics, pain control, CISBAPs. Anal fistula. Move on. This is an abdominal tract connecting the lower rectal mucosa or the anus to the perianal skin. And about 95% of cases are primary. About 5% are secondary. We see many of the primary ones. We have seen a few of the secondary ones, ulcerative colitis, carcinomas of the anus and other things, but majority of those we treat are cryptoglandular in origin. And for the pathogenesis of the cryptoglandular one, we know a blockade in the anal ducts that leads to cryptitis, that leads abscess formation, and the tracking of abscess to point and rupture in the perianal skin. And this picture is trying to demonstrate, you can find them everywhere. The anal glands are there. The anal glands in humans produce a small amount of mucin to lubricate the anus so that fecal matter can come out. In animals, they are more elaborate and they perform a sexual function. Ours doesn't do that. That is why you see the goat, he-goat going to put a nose at the back there and does that noise. Ours is not like that. So the anal glands have valves that will open to squeeze out mucin to lubricate the anus for fecal matter to come out. After they close for the fecal matter to come out. But when the valve fails to function properly, fecal matter can enter the duct, cause infection, the cryptitis, and abscess formation. Basically, that is it. So once the duct is on, remember, the inner part of the duct is epithelialized. And once no granulating tissue, healing may be difficult. Sometimes the external one is also epithelialized, but for the inner one, we're almost sure in many of the cases. So if that is not dealt with properly, recurrence is very high. So we have a couple of classifications for them, but I prefer this anatomical classification because it helps me in the planning for the patient. The submucous tract, the subcutaneous tract, interstitial tract, transvitreal tract, supraspinatus tract, and extraspinatus tract. For me, the surgeon, when I see and I'm able to make this diagnosis, then I know how to plan for the procedure. So this sketch tries to show us these tracts, the submucous tract, that is going in between the, below the mucosa, submucosa, and come down. The intersphincteric tract goes in between the two sphincters and can open low, mid, or high. And the high one can be confused with the suprasphincteric tract. You have the transsphincteric, the suprasphincteric, and then the extrasphincteric. Now, we also have the classification by the St. James University Hospital, which is a radiological classification system. But it's based mainly on direct tracts and its complications. So a simple linear tract, interstitial tract with abscess and a second tract, transsphincteric tract with an abscess or another tract, and suprasphincteric tract. When you have the suprasphincteric tracts which make a curve, it becomes difficult to use this classification. I don't have experience with that. Investigations, you need to define the anatomy and the number of tracts. You need to assess the presence or absence of a foreign body abscess. You need to identify the internal inner sphincter, and that's the most important thing, to define the relationship between the cause of the tract and the two inner sphincters, and to exclude granulate diseases and malignancy. Because if you don't exclude these ones, whatever you do, you will get a recurrence. And there's a young girl I treated. She was operated 5 times, and the last one was 8 years ago, and she gave up. She said she used ChatGTP and directed her to my hospital. And this is where the failure was. This is an internal opening that has consistently been mixed. And once you get it and you fix it, the girl's problem will be solved. So those who are doing it 5, 6 times, don't go and create a colostomy. Because if you create a colostomy and this is not fixed, it will recur. Let's make progress. So fistulogram, transperineal or endoluminal ultrasound is very important. MRI is the gold standard now. For us, it's expensive. For us, it's expensive. And for entrepreneurship aspect too, because other methods can tell you the tract relationship with the muscles. And if you use diluted hydrogen peroxide, I used to do methylene blue, I stopped because it stains the tissues. You can find the internal tract and pay attention to the internal tract. Sigmoidoscopy, colonoscopy is very important. If not, you miss a diagnosis and come in trouble. Then this other. Now, back the issue of histopathology. Yes, in the teaching hospitals, you may not do anything about it, but we are told you need to send them for histology. You'll be surprised what you can find. In private practice, every fistula tract goes for histology because of future problems. So, intraoperatively or enzymatic anesthesia, you get hydrogen peroxide diluted, pass it through the external tract, you will see the internal tract over there. And spend all the time of the surgery fixing the internal tract, not the external tract. And use the approaches that have been described, you master them, and you close that tract, this other tract will heal. So the second approaches are fistulotomy, fistulectomy, certain placement as a primary treatment, or to drain an abscess to make the tract thin, to make the surgery easy. Then we have the mucosal advancement flap, the lift, ligation of intersegmental fistula tract, placement of antibiotic beads. Then we have the minimal invasive one, the visual assisted fistula treatment, the use of the laser, and now selection of patients for the different approaches. Because it's not one heart fits all. And you should decide which procedure you're going to do for which. So if fistulotomy and fistulectomy, for some mucosal ones, low intersphincteric ones and intersphincteric and low transsphincteric, yes, they may work because you don't want to touch the external sphincter. Then for the lift, mucosal advancement, and then the valved, mid, and high transsphincteric, suprasphincteric. Certain placement, as I said, it is for continual drainage of the abscess so that the tract becomes thin. You don't have sepsis in the place. You're going to operate. It's easier. Some people leave it as a primary treatment. I saw somebody whose own was there for 5 years. Fistula was there. We had to go and fix it for the person. Last but not least, anal fissure. This is simply a crack in the anal mucosa. Almost all those I see here are posterior, but they can be lateral or can be anterior. And this crack, of course, it's a cut will go to inflammatory process and supposed to heal. Many will heal. But there are some which are recalcitrant. They will progress into an indolent ulcer, a chronic indolent ulcer, and they will not heal. And they will not heal because in the inflammatory process, the fanciolaser, that the spasm to protect the ulcer reduces the blood supply to the ulcer. And in the ischemic phase, the ulcer progresses into an indolent ulcer. So the first picture shows the acute phase. The second picture shows the chronic phase, where there's a heaping up of collagen to give the sentinel pile. Go back and let me see. So yeah, that is it. Let's make progress. The next. So this one, if somebody tells you has severe anal pain, for God's sake, at the clinic, you don't stick your finger into the anus. If you want to do anything, you have to do examination on anesthesia. You know, the patient was working in your office, has no pain, and leaving the office in so much pain. So it's not anesthesia. And I think doing the examination and come for a second, this thing is very difficult, unless surgical treatment is not an option in that patient. I treat the patient at the same time. So to get this chronic indolent ulcer to heal, the spasm of the internal sphincter must be relieved, either medically or surgically. There are many things prescribed in the vitamin ointment, paste, glycerin trinitrate, and Botox. When I heard the price of Botox in Ghana here, I said, well, let's take our time. Move back. So for the surgical approach, you have the Law's procedure, you have the internal sphincterectomy, which can be done with an open knife diatomy or with a ligature. We're still trying to gain expertise in the use of the laser. I have not used it yet, but some training has been going on at the Colorectal Hospital where the young consultants have been trained how to use it. They will look at the results and tell us later on whether we should move there, because laser is not cheap. One laser fiber is expensive. And our patients don't want to pay for these things. If you know, we have to encourage them to pay for these. The machine itself costs money, and the fiber costs money, and the patient don't want to pay for it. It can go for free. Use a knife cut and let them go. So basically, I have gone through in a very fast manner, because yesterday I was there when told me that he has given only 30 minutes instead of 45 minutes. So I became a bit jittery. I didn't want to change my slides. So thank you very much. I hope I've told you something you can go and read more on, but you are free to ask me some questions. Thank you very much.
Thank you very much, Prof. Indeed, you've said a lot. Please, any questions?
Thank you, Prof, for the insightful presentation. Your discussion about the treatment of fistula and anal, you talked about sit-in stitch as one of the treatment, but it's like you mentioned like a temporary procedure for the drainage of any abscess before any definitive procedure. But I've seen people use it as a permanent method of treatment of these fistulas. Please, what's your opinion about using it as a permanent way of treatment for fistula and anal?
I have not used it as a permanent method before. If you look at the history behind the history of Satan, described by Hippocrates, his idea was that if the fistula was too high, you don't cut through the sphincter, you put the Satan there. And that was a tight Satan. You tighten it periodically so that as it is cutting through the inner sphincter, it is healing from upwards. So by the time it falls off, it has cut through the sphincter and it has healed, so you don't have incontinence. That was the basis. Now we moved on to have the loose Satan, who they say that, oh, by the chronic inflammation, that can do the same thing. But many people, it has been there for years before it ever does that. So the use of Satan actually have almost gone out of use in proctology. But then we realize that no, if we bring it back, it could serve another purpose, and that is, you've done your investigation, you said there's an abscess there. There is sepsis there. If you go operate, the sepsis alone can break down your repair. So why don't we dry the fistulous tract, shrink it, so there's less tissue damage? So now it's coming into vogue, mostly is for treating an abscess, and then to go in and do a definite procedure. I've never treated fistula completely with a set. The few I have put is just to drain the abscess 3, 4, 5 months time. I'll go back, operate.
Any other questions, please?
Thank you, Prof. Dakabu. That was a really great presentation. And I love that you took the regional health minister's point about relating to our local context. And I think that's very, very important. I will disclose I don't practice here in Ghana. And so whatever I say, please take with a grain of salt, and we'll defer to the more experts here. In our part of the world, we see a lot of patients with inflammatory bowel disease, so with Crohn's disease. And in those patients, when they have active inflammation of their anorectal region, it's very hard to do a definitive repair for a patient who has a fistula. So we do have patients who have setons in, not in terms of the intent being as a permanent repair of in the periphery and much muscle to cut, just put in a seton and then refer them to a colorectal surgeon or tertiary center so they can do a little bit more of that complex thing. Because cutting, especially in our younger ladies who might choose later on to get pregnant and have a baby, and then if they develop an episiotomy or a big tear, and then that's the end for them. And then it comes with all these social implications to come in there. But thank you, Prof.
Thank you very much, Prof. Pachi.
Okay, I don't think in the past 10 years, we've been done fistulectomy. Since we started colorectal units, we've not done it before. It's either left because of advancement. We don't touch the sphincter. So also in our unit, you see, we don't cut the sphincter. We are in the anus until we have closed that hole there. Then we do the external one. We don't do fistulectomies.
I think my take home from all this is at least diagnose it, know what it is, and send the person off to the appropriate place to get the best treatment. Because the worst thing you can do is saddle someone with morbidity that they would have to live with for the rest of their lives. And so on that note, we'll take a break, go for snack. You'd realize on the schedule it's for 15 minutes. And we'll just go down the stairs, pick a snack, and come back with it into the room so that we can continue and keep to time. So please, 15 minutes to stretch, grab a snack, and come back in. And that would help us keep to time. You'd realize our next session is to start at 10:45, and we want to be able to do that. Thank you very much. be delivered by another professor of colorectal surgery. He's the lead for, he's a colorectal lead for the global surgery unit in University of Utah in the person of Professor Lien Huang. Please, shall we welcome him with a round of applause, please?
Oh, perfect. Even better. Okay. Oh yeah, no, he showed me. Yeah, that's great. Great. Well, thank you for the opportunity to speak here. It's a real privilege and honor. I really have to thank the organizers and all the leaders at the college and Kopanoche and Korlebu for inviting me over and over. So hopefully it's been fruitful on both sides. And it's honestly led to some very wonderful friendships. And I did not include them in the slides today, but I wish I had included some pictures of Kwabanag Bandino skiing in Utah the last time he was there. And so if any of you want to come and ski, I'd be happy to show you and teach you. So today, or that might frighten you all away. So you don't have to if you come. So let's dive in here. I just have just to say that I have no disclosures that are relevant to this presentation. And what I talk about today is really my opinions and not the opinions of the University of Utah or any of the organizations that I work with. In particular, I sit on one of the committees on colorectal cancer screening in the US. And so this does not represent their views. Today, I'm going to be talking about these 4 items, the epidemiology and risk factor of colorectal cancer and so on. Honestly, you could probably send an entire workshop on any of these points. So I will go through, but please feel free to ask me questions afterwards and we can dive further into details, particularly for your context, as well as I'm happy to talk at any of the breaks. So, oh, I see. There's a pointer there. Okay. So globally, colorectal cancer is now the 3rd most common cancer in men and 2nd most common in women. So it has actually been kind of creeping up in the incidence and prevalence as well as cause of death. So in the US, it's also become one of the leading causes of death from cancer in the United States. And globally, the incidence of colorectal cancer has doubled in the last few years. And this was probably the most recent number I could find was 66,000 cases of colorectal cancer in Africa in 2020. And that's probably a gross underestimate, as I'm sure all of you are aware of. And that number is expected to double in the coming decades. And so this is a major problem. There are a number of risk factors that are associated with this. For those of you who are in the medical field, you'll have looked at all of this in the textbook, but just to go through, a number of patients will have hereditary syndromes that are related to the colorectal cancer, either a personal or family history of having adenomatous polyps. Inflammatory bowel disease is another cause, prior abdominal or pelvic radiation. And then we get into some of these factors here that are a little bit more difficult to quantify. If you're a researcher, you'll find that these are not strong associations, but there's definitely associations with having a diet that involves red and processed meats, ultra processed foods, and sugary drinks. And then lack of a physical activity and obesity generally is also associated with a higher incidence, more nuance to that. And then heavy alcohol consumption or smoking is associated with that. Sort of conversely, and sort of as you would expect, the protective factors that we can look at are primarily around diet and lifestyle. And as you may know, for colorectal surgeons, our favorite thing is fiber. So you should all have fiber. And particularly in the US, we have a fairly low fiber diet. And so this is often has many benefits besides colorectal cancer prevention. But diet high in fiber is associated with a lower rate of cancer, as well as there's some data to suggest some of these factors. I wouldn't take any of these as a reason for you to go out and buy supplements in this area, but because the data I think is not as strong as we'd like, but there is an association with these things, and then high in dairy, and then lifestyle factors, staying active, healthy, and being healthy weight, and then avoidance of smoking and heavy alcohol consumption. I will note that, we talk typically about colorectal cancer, even in my lifetime, has gone from a disease that we were primarily focused on the older population. We are screening in the United States used to start at 50. And this was really a disease of kind of the later decades of life. And now we are seeing an increasing incidence in young people. And certainly in my experiences, anecdotally here, in the patients that we've cared for here, many of them are presenting much younger. And so I think this is something that it has to be much earlier. The point here is that it's much earlier on your differential. It doesn't mean that you're likely to encounter it. I see, I don't know, thousands of patients with hemorrhoids and painless bleeding from the rectum. And that doesn't mean most of them do not have cancer. But that's certainly something that you should keep in the back of your mind as you're treating hemorrhoids, for example, that maybe this 25 or 36-year-old with hemorrhoids has bleeding that doesn't seem to be improving with treatment, that maybe the next steps should be considering the possibility of the presence of cancer. In the US, I don't actually know the data for here, but in the US, colorectal cancer is rapidly rising in patients between the ages of 20 and 40. And actually, the incidence is slightly decreasing over the age of 65, although again, most of the patients are still older who have this. It's become the top cause of cancer death in men under 50 and the second leading cause of cancer deaths in women under 50. And I put up here that about a third of those are from hereditary syndromes, not to say that because that's the thing that should cue you, because many of these patients, you'll be already sort of aware that you should be thinking about cancer, but that many of these patients are developing it spontaneously without family histories, without hereditary syndromes. And so that it should be, in your differential when you're thinking about it. So screening and early detection strategies. So let me just stop here for a moment and make a kind of clear distinction. We often talk about screening versus diagnostic. So here we're talking about screening for patients who do not have any other symptoms that would make you concerned that they might have a cancer. And so there are a number of modalities that you can use in populations for this. Colonoscopy is considered the gold standard in that you can examine and also treat polyps before they turn into cancer. There are other also screening, but you can use flexible sigmoidoscopy, which will only examine the left side of the colon, but give you a good view of at least that. And at a population level, that can be beneficial, although that's not what we try to kind of shoot for. And then there's a number of different approaches. The most common that you may be familiar with is stool-based screening modalities. So fecal blood test, essentially just testing for the presence of blood, and then more advanced forms such as fecal immunochemical testing or FIT testing, and then these newer ones that are multi-target stool DNA or RNA. So these are more specific and sensitive for the diseases. CT colonography. So this is a special CT scan done with air insufflated into the colon. The idea is to use 3D reconstructions where the radiologist is able to examine the whole colon and look for polyps. The challenge of this is was initially very popular because nobody wanted to have to deal with going through the procedure of a colonoscopy. But the challenge is if you find something, then you still have to go to the colonoscopy. And it is still favored in some areas, but I would think it sort of was popular and then has faded. But it still has a use. Some of the more complex patients, for example, that have very difficult colons to complete colonoscopy may choose to have this in the right setting. And then I think in the last year, this is actually an exciting time. We've now had the release, and at least in the US, the approval of blood-based testing and screening modalities. So now you can look at draw someone's blood and test for colon cancer. I think there are more to come, and I think we're in the first generation of many of these tests, and so the second generation and third and so on, I think will become not only cheaper but better. I put this slide in here just to kind of think about, because this is something that Dr. Agbedeenu, I think, is thinking a lot about. And we've heard from the Ministry of Health that, this is something that they're thinking about very carefully, which is what are your screening strategies that you can do at a national level? And, obviously one of the biggest limiters is if you're going to screen a population, you need to also be able to then take the patients that are positive and then take them further down the pathway to diagnosis, typically with a colonoscopy. In the US, we've really pushed the colonoscopy strategy as our main screening strategy. And up until a number of years ago, we started at age 50. We've actually dropped that age down to 45 for younger, because of the rising incidence in younger patients. And my anecdotal experience is I think it helps because we've certainly caught more things. The challenge is that even in resource-rich areas, colonoscopy is a very resource-intensive method for doing screening. And it requires a lot of, and so we don't have the capacity to actually, if everybody actually showed up to get screened in the US or, Europe, with a colonoscopy approach, we actually couldn't handle that capacity. My own health system is booked out about over a year just to get your screening colonoscopy. A lot of countries in Europe and other countries, and actually other countries like I think Thailand has falls in this category, have taken on a national screening approach that's stool-based. So they will test the stool first, typically with FIT tests. I wouldn't be surprised that the more sophisticated tests as they get cheaper will become used there. And then if you have a positive test there, then you will order the follow-up colonoscopy or the diagnostic colonoscopy at that point. There's some evidence to suggest that even doing a flexible sigmoidoscopy in that setting, while it doesn't look at the complete colon, may, at least at a population level, provide a survival benefit. But, again, you have to, there's a really difficult balance of resources here. So I bring this up just to kind of stir the pot and get you thinking about this, because this is a challenge for everybody. And with the incidence of this disease, I think everybody is thinking about how we can do this more efficiently. I'll also just point out here, and this is, I think, drawn out of research that we're actually working on right now at Confanoche. There's also questions. The truth is, most of these studies have been done in places like the United States with our diets and our contexts, or in Europe. This was a study done in Nigeria by Dr. Alatise and his group. I want to say it's like 3,000 or 5,000 patients where they were doing FIT testing, screening for colon cancer. And one of the challenges they found is that they are having a higher false positive rate associated with those FIT tests than we were seeing in other countries. And they did a very nice kind of comparison. And their thesis is that the ovum parasites burden is higher, and that may be contributing to the false positives. And they did a nice study. You can take a look at the study, but this is a challenge, right? Because now if you're getting more false positives, then it's going to put a burden on the system when you ask them to do diagnostic colonoscopies. So we're hoping to replicate some of this work here in Ghana coming soon. So more to come. All right. Let's talk about the clinical presentation and diagnostic approach. So again, as I forget who said earlier, if you don't think of the problem, then you're not going to identify the problem, right? And so these are the most common symptoms that patients are going to present. At least I believe this data is out of the US, but I think it's very applicable to how the patients will present with colorectal cancer. So blood and stool or blood per rectum is the most common, and generally we sort of describe it as painless, but that's also is consistent with any number of other benign rectal diseases, as Prof. Dakabu noted earlier. About a third will present with abdominal or pelvic pain and bloating, and then about a quarter will present with changes in bowel habits. And then iron deficiency anemia is actually a very common cause in the sense that we see that diagnosis, the primary care physicians will diagnose it, and then if they don't have a good cause, or they may just even reflex to a colonoscopy, especially if the patient hasn't had one already. And unexplained weight loss and fatigue was kind of the fifth most common symptom. Okay, so I'm going to take a little detour here. Yep. Okay, there we go. About the physical exam. So of course, as we learned in medical school, the vast majority of diseases and diagnoses could be made often by a very careful history and physical. And I think we do a fantastic job of teaching medical students, our trainees, to do very thorough histories, although of course you want to be very targeted and ask specific questions. And that's why I put the symptoms up earlier as part of the symptom, history taking. The physical exams are important, particularly because we were talking about colorectal cancer. The colon cancer, by the time you're feeling a mass in the abdomen, it's probably fairly advanced. However, rectal cancer is a little bit different. And I've seen many patients who have, come to me, and along the way, if you look at the notes, nobody has gotten to the point where they've actually done a rectal exam. So I'm going to take a moment to talk about a rectal exam, because I think it's a really important skill and something that you should feel comfortable with. And honestly, if the more you do on normal patients and feel comfortable, then you feel comfortable asking to do it. And then you feel comfortable comparing the normal exam versus something abnormal. And so at least in my training, we had a comment that there are really only two reasons why you should not do a digital rectal exam on a patient. And I think this is a broad generalization. Please don't do it if the patient's coming to you for some other, like oral issue or breast issue, and that's not indicated. But, the two reasons were the patient has no anus or you have no fingers. Okay. This is actually my group at Utah. One of my surgeons has left and our PA, but I just want to point out that these are the people that you want to see when you come to the clinic. She's doing it correctly, Dr. Cohen, Dr. Picaron. You probably don't want to see me if I'm using both hands. Jenny was doing a great job with one finger, and Luke is being absolutely sure with 2 fingers. You don't need to use 2 fingers. Okay, so when you start an anal rectal exam, you're going to look on the outside, start with an external exam visual, right? You might need to spread the gluteal cheeks to take a good look and take a look at the skin around the area and look for abnormalities, dimpling, hardness, and induration, many of the things that we talked about in the benign anal rectal section. Then I think the next most important thing is actually the digital rectal exam, because, as you do it more and more, you become more sensitive to picking up things, and you can examine many things. I won't say you can replace anal rectal manometry, because Dr. Lowry will disagree with me on that, and I would actually agree with her. But you can start to test the pelvic floor with digital rectal exam. I'm not going to talk about that today, but then with coaching to the patient and making sure that they're not surprised, you're going to carefully put your finger in and take a feel. And you really want to go in and take a feel all the way around and feel comfortable that you're rotating all the way around, feeling the top of the pelvic floor as far as you can, depending on your finger length into the rectum. And then you can, of course, examine many other things while you're doing that. But it's probably the most sensitive thing to pick up, at least the mass. And then you can see that. And then the last step is anoscopy typically, or you might use proctoscopy if you're comfortable with it, but anoscopy, just looking at the mucosa, and then if you can see the mass. I'll be honest, many times for rectal cancer, it's going to be very difficult to see the mass as much as we'd like to or see it, but it can give you a sense of that. I could spend all day talking about the rectal exam. I just want to, this is my own personal preference, so take it as a opinion, but I'll give you some reasons for why. I really encourage my trainees not to report their findings by the clock face. So I've got the X there. And the reason is that as colorectal surgeons, we spend a lot of time examining patients in different positions. So typically in my practice, when they're in the clinic, I'll examine in the left lateral decubitus, but many surgeons will, as a default, examine in the prone jackknife position. And then when you go to the operating room, you might put the patient in prone jackknife, or you might put them in high lithotomy where they're lying on their back. And the question becomes, what is 12 o'clock, right? And many times people do not document that. And that becomes very difficult. Sometimes it's not a big deal. You're going to find the fistula opening anyway, but sometimes it's a little bit more trickier than that. And so if you can describe it in an anatomical terms, just like we would anywhere else in the body, then it makes it much easier for those of us reading your documentation to find the mass again. So, we would, nothing else we do in the rest of the body is relational as far as I know. This is still my right arm. This is my left arm, regardless if I'm facing you or turned around. And so this is why I encourage my trainees and my faculty to describe things in anatomical terms. So does that make sense? Okay. I'll get off my soapbox. We'll keep going. All right. Diagnostic approach. So I mentioned history and physical is really important. The digital rectal exam, anoscopy, and proctoscopy. Particularly for the rectal cancers, as a surgeon, one of the most important things I need to know is where is the tumor and how far is it from the anal verge, and does it involve the sphincter complex, particularly for the rectal cancers. And that can be, rigid proctoscopy can be very helpful in that range. I suspect that most of us actually have lost many skills that the original proctologists had and could do incredible maneuvers and exams and things like that with rigid proctoscopy, but it is still a very useful thing to feel comfortable with. And then if you have the good fortune of having flexible endoscopy in clinic, which even many clinics in the US do not have, I found that to be incredibly useful for examining the patient, but also documenting in terms of photography, examining length, and kind of surgical planning. Oh, I have that there. Okay. I think I included it. Just a reminder, don't use the clock. I will just comment that, we're typically taught that CT is not that useful for detecting or screening for colorectal cancer. However, the truth is that many patients are coming in these days with CT scans. What is interesting is that many times the initial read on the CT scans will miss a mass, right, or a concern. But when you tell the radiologist that you are concerned about a potential malignancy, or if they see that there's an endoscopic report, then the detection rate of the cancer goes up somewhere like roughly in one study from 50 to 80%. So the reason I say that is because many times the patients will come with the CT and then you say, oh, the CT scan doesn't show any masses, you're not concerned, and then the item colorectal cancer falls farther down your differential, but you should be aware that this can be missed on CT. And so don't, rule out based on that. At the same time, it may be worth going back to your radiologist and having a conversation about it. Obviously, the bigger the tumor, more advanced, you're more likely to see it. Okay, So staging and treatment. So you have a patient in your office that is has a diagnosis now of colon and or rectal cancer. And so this slide basically gets at the difference between the two. So typically we'd still get a CEA for staging the lab. As a general rule, it's actually not that useful in this point, but it's a great baseline for later. Down further down, you can track on once you've resected or treated the tumor, you can use that to track recurrence of the tumor, but not the greatest test, and there are probably better tests coming. Typically for both of them, we're going to be concerned about distant metastases. So we'll get a CT chest, abdomen, pelvis for both. And then the key thing here is that rectal cancer, our staging is based on the initial imaging. So we add either a rectal MRI or endoanal ultrasound. There are nuances between which one you can choose. If you can choice, generally for most of us, we would take the MRI because it's easier for us to review and compare. But if you don't have access to MRI, and endoanal ultrasound can be helpful as well. As I said, the primary form of staging. So when you're actually going to go stage this, assuming it's not metastatic, your pathology specimen for colon cancer is actually going to tell you your T staging and your nodal staging. Whereas on rectal cancer, we're going to start with imaging. And that leads into also the treatment options, which I'll go into briefly today, which is that, generally as a general rule, if the patient presents with a colon cancer, your first step is going to be surgery for both therapeutic purposes, but also because it'll give you the staging that you need to know if you need adjuvant therapy. Conversely, for rectal cancer, I would say that when I was in training, we started off with a typical regimen that if you had a rectal cancer and it was a stage 2 or 3, we'd start with chemoradiation and surgery and then chemotherapy. We've essentially moved to complete regimens now that are all neoadjuvant. And there's a lot of nuance. And I'll point that some of the details out, but that can be a topic for an entire conference over multiple weeks and create debate. But it's very exciting because I think things are changing and for the better. And as I said before, we rarely use neoadjuvant therapy for colon cancer, and we commonly use it for rectal cancer. Broadly, so, in the textbooks and on exams, you might have to remember the right side of the screen with all the kind of details. But honestly, I'm a simple person, and I just remember the stuff on the far side, the right side, as the right side of the screen, right? So if you have a T1 or 2 tumor, that's going to be a stage with no nodal involvements. That's going to be a stage 1. Stage 2 will be T3 or T4, but still no nodes. As soon as you have nodal involvement, it doesn't matter what the T stage is. It's going to be a stage 3, and then if you have metastases, it's going to be stage 4. So really, you can bucket those treatments into that regimen. For colon cancer, as I said before, really surgery is kind of the first thing. And honestly, you're not really going to know the staging most of the time without doing surgery. So unless you know that the patient has stage 4 disease right up front, generally you're going to go to surgery. Obviously, optimization, finish that. And then, if you have stage 1, you'll go to surveillance. Stage 2, I'll briefly cover that. You may consider adjuvant chemotherapy. Probably most people should not be getting chemotherapy at stage 2. I'll get to that. And then for stage 3, chemotherapy carries real survival benefits. For stage 4, most of those patients, you really have to, that's a complicated topic, but I'd say most of them will start on chemotherapy, and then you have to make a decision whether they are potentially curable or at least resectable and go on for surgery. I want to take maybe a minute or two to talk about endoscopic excision, because I think many people often do colonoscopy and don't feel comfortable. So we get a lot of referrals about this. So many times a patient will come in, you'll get a polyp removed by an endoscopist. And if they may have completely removed it, and then the question they'll send on to us is, do they need to go on to have further surgery or further treatment? And so I won't go through this, but this is just know that in the textbooks, you can go and find this. These are the criteria for when you should be concerned that removal of the polyp should lead to further resection. Basically, the more advanced and malignant it looks. And then usually you're trying to look at whether they removed it. And piecemeal resection, I think, is probably the most challenging one, because many times the patients will have it piecemeal removed and maybe completely removed, but you just can't prove that point. For pedunculated polyps, really you're looking at, can you get a negative margin? And it can be as low as 1 to 2 millimeters. That's what you're really looking for. And then for non-pedunculated polyps, really we're kind of looking at cancer at the resection margin. Did you get it? And did you at least get a little bit of a margin? So these are things, these might be situations where you might consider that if you don't have these features and you got the clear margins, that you might not need to proceed to surgery. In the interest of time, I'm not going to go through this, but just know that I think for stage 2 chemotherapy, we have this long debate and discussion with the patients about whether there's a benefit or not to using adjuvant chemotherapy. Data has shown over and over that we generally probably overtreat most stage 2 cancers with adjuvant chemotherapy. Okay. I'm gonna kind of skip a bunch of other slides, but I want to just kind of talk a little bit about colon surgery very briefly. So, this is a topic that we can again spend a whole week on. But really, when you think about what's the goal of cancer surgery, we're trying to remove the primary tumor, and we're also trying to get staging. And so we want to find out if the tumor has spread. And so, this was a big thing, at least before my time as a trainee, but I think is something that we've been really working on in the US, which is to make sure that you have adequate removal of the primary tumor with good gross margins. I think most surgeons feel very comfortable with that. And then the second part is getting adequate lymph node retrieval so that your pathologist can tell you an accurate staging. Because if you only take out 2 lymph nodes, and if you take the mesentery high, and so that you don't really take much mesentery, you're just taking the primary tumor out and you leave the mesentery behind, you don't know if the tumor is already spread and they're actually a stage 3. So at least in the US, the target is a minimum of 12 lymph nodes in your pathology specimen. And there's technical things that you can do to try to make sure that you get that. And then I'll just say that, again, there's surprising variability in what vessels you should take or how widely you need to take. How aggressive should you be in the resection? So these slides I was just going to go through, but I don't, this is for the surgeons in the room. I'm happy to sit down and talk about this more, but essentially you really want to take the mesorectal lymph nodes that are appropriate for your colon resection. You don't want to be cutting right along the colon. So I'll just skip through this anatomy and we'll kind of go through here. Happy to show this later. Okay. I'm going to say something about rectal cancer treatment very briefly. Well, not briefly. Rectal cancer treatment. This is a photo of the inside of one of the Apollo capsules we used to send people to the moon. And I just show this because there are many switches. I have no idea what any of these switches do. I don't even actually know if this is actually meaningful control, or if this is control as like the bathroom or something like that. But it just goes to show you that right now where we are currently is in terms of rectal cancer treatment is heavily in evolution. And so I think things have changed dramatically in the last few years. And I'm actually really excited to see where it goes forward. Very broadly, if you have a stage 1 cancer, you're going to be thinking about surgery up front. If it's a very low grade or potentially not very aggressive tumor, you might consider transanal excision followed by chemoradiation afterwards for the slightly more aggressive ones. Versus a big abdominal surgery, we take out the rectum and then you have to do a low anterior section or abdominal perineal resection with a permanent colostomy. This will change, I think, in the next 5 years to look more like stage 2 and 3, because now in stage 2, 3, we used to do radiation, then surgery, and then chemotherapy. But now really the standards are starting to drift to what we call total neoadjuvant therapy. We're doing the chemoradiation up front, or the chemotherapy up front, or the short course radiation up front, or the immunotherapy up front. And the goal here is that, the Brazilians and the Europeans have really pioneered this, that we are seeing a good number of patients, not all, but a good number of patients, third, who are having a complete response to just that treatment alone, and they can skip the surgery, right? And if you tell a patient that I could potentially avoid giving you a permanent colostomy for a low anal cancer, or I could avoid giving you low anterior syndrome with a LAR and avoid a diverting loop ileostomy, they will jump at that. And so we've really revamped our whole system around this, and the outcomes are very promising. So this is where we're going, and it's really a matter of tweaking and finding the right patients for each of these. And then generally for stage 4s, as I said before, we'll do chemotherapy and then reevaluate. Transanal excision is actually one of those things that we talk about, and it's actually, I think, one of the more harder things we do, even though it seems like it's a trivial thing. But I'm just going to put these criteria up, and just know that these criteria exist to guide you in your treatment. So you really should be looking at tumors that are T1s without any nodal involvement with favorable histology, and or patients who maybe are not fit for undergoing radical excision. Although you can make an argument that maybe those patients should get radiation. And then kind of the textbook criteria is that it's within 8 centimeters of the anal verge, occupies less than 30% of the rectal circumference, and less than 3 centimeters in diameter. And we're pushing all the boundaries of all of that, but I think that is a good place to start, especially if you're not comfortable with it. And then finally, I'm going to conclude here really just talking about total mesorectal excision. This is a topic that, again, you could spend weeks on, but really, the idea here is that it's important to take the mesentery with the primary tumor and to take it well and not to cut into it. So this is what I hope this is a good specimen here with the mesorectum intact. You can see it on the side here where the mesorectum, basically what we're looking for is a shiny. There's a shininess. One of my partners at Utah describes it like a hot dog bun. So it's actually a hot dog bun wrapped in saran wrap. So here's your rectum, right? Here's your mesorectum right here. And then actually she describes it as having a saran wrap or plastic wrap around the outside. And you should be able to preserve all of that, because the idea is you don't want to be cutting in to the mesentery and then accidentally cutting in and leaving behind lymph nodes, or compromising the tumor. You really want to have a nice clean edge all the way around the edge. And frankly, this is probably like, I don't know, a third of our fellowship training is trying to get this right and do it properly. And if you look at the data, even in the hands of experienced surgeons, we're still only getting about maybe like 90% complete TME. So this is not a trivial thing to do, but it's something we strive for, but it's challenging in a radiated field, or having other issues. This is just some anatomy, essentially kind of emphasizing the point that you're trying to preserve these planes. The dotted line is ideally where you're going to cut. I'm just going to make one more comment. This will actually be close to the end. So we talked about total mesorectal excision, but there's really, I think we should define it a little bit better. My partner likes to call it tumor specific. So if you have a tumor that's sitting down here, very low, you really want to probably get all the mesorectum all the way out, and you're dissecting all the way down to the pelvic floor and then connecting the anastomosis down at the bottom. But if you have a tumor that's at like 12, 13 centimeters, you probably don't need to go all the way down, because you'll compromise their long-term quality of life function, higher risk of anastomotic leak, and so on. You can come down, preserve that mesorectal plane, and then get it to a point 2, 3 centimeters, 5 centimeters below the tumor, and then come across and divide it cleanly and try not to cut through the mesentery and try not to, come towards the tumor. So we'll call that tumor-specific TME. I'm promoting that term because I really like that one, versus a true total mesorectal excision. Okay. So just to review, we covered epidemiology, screening, early detection strategies, clinical presentation, and the basics of staging and treatment options. That's my email address. You're welcome to email me and ask questions if you like, or afterwards, or slides, or anything else. So let me stop there.
Perfect timing. Thank you very much. Please, any questions?
Thank you very much. And thank you so much, Professor, for a wonderful presentation. There are a lot of people here, but for me, my interest is epidemiology. As a public health, epidemiologist with so much focus on cancer prevention, I'm particularly interested in modifiable risk factors. Yeah. And then your presentation highlighted various risk factors. And I would like to draw your attention to a recent study, a Ghanaian study actually, by Na Azua et al. 2023, just last 2 years. She found that red meat, among all the modifiable risk factors she studied, she found red meat consumption to be strongly associated with colorectal cancer. At a p-value of 0.023, very strong, but also found a weak correlation of 0.41 odds ratio. So albeit with a weak correlation, what insight can you share on these findings if you want to share, and their implications for preventive strategies? I would like to know whether you can elaborate on some potential biological mechanisms underlying this relationship between red meat, and colorectal cancer, and also suggest avenues for further research to better understand this association in our population. Because I'm interested in it so much. Thank you.
Wow. Okay. I think there are probably several thousand researchers that would love to answer that question in detail. So, as a general rule, for those of you who are familiar with the statistics, right? Like if you look at, this is not smoking and lung cancer, right? We're talking about odds ratios of like, 10%, 20%, depending on the study population that you're seeing. So from a screening standpoint, I think it's extremely challenging. And from a public health standpoint, it is extremely challenging. I'll just share, I'm going to dodge your question for a moment, because when I was a fellow, my program director was a vegan. So he ate no dairy and no vegetables. The Mayo Clinic had this deli that served fantastic pastrami, which is a smoked meat. And I kind of forgot that. And we were actually talking about the epidemiology and risk factors of colon cancer that day. And I came in with my pastrami sandwich and he said, "How can you eat this? You're a colorectal surgeon." I said, "It's delicious." So I think from a screening and public health standpoint, I don't know that we know what to do with that other than I would say everything in moderation, right? Like everything that we've found in history so far in science, we find these signals and then we find everything comes in moderation. It's, when you take it to the extreme, that I think you see some of these challenges. So if in terms of public health messaging, that is what I would phrase it as, because I think it's a big ask for people to say, you can't have any red meat, right? Like that, especially if it's integrated in the culture, it's part of, it's part of your culture. That may be really important, right? There are many benefits to that, but I can also tell you that there are people who had to add red meat back into their diet because they are elite athletes. So, they're examples. The mechanism, like I'm not a basic scientist. I think there's some issues probably around stasis in the colon with bacterial loads, microbiome, the relationship of the bacteria in the colon. Probably some immunogenic components of red meat that activate the immune system that then interplay with the microbiology. And I think you could probably find papers to cite that and more that I can't think of off the top of my head. I think all those questions are valid. And I think the important thing for you is that these questions are not being answered in Ghana, right? Because these things do matter. Where you are matters in terms of the effect on all these other things, right? Like I mentioned the Nigerian paper, we can't just come in and say we should all do fit testing because that's how we do it in the US. Because if you have your false positive rate is twice as much, we'll overwhelm the system even more than we have in the United States. And so it does take those studies to answer the context. And I think someone noted that earlier, that we really do need the research here. You guys have the Kumasi Cancer Registry. You have lots of resources. You have lots of great trainees. I think the questions you ask are the right ones. And I think the trainees are the ones that we're going to go out and answer those questions. That result.
Thank you very much. In fact, by now, if you are doing MPH, you are coming to do fellowship, you started writing some research ideas down, isn't it?
First, to congratulate, thank you very much. Very, very interesting point of view. Our big challenge, the big challenge for us here, I think, is to adapt the international guidelines, Europeans and United States and the developed countries to adapt to our environment here. So to do that, we need the same you have there, a trustable and confident data collection. And that's the first thing, is very weak here. There is a sub-register, in our modest opinion. I don't know, maybe in other environments, but yesterday we did a big operation, me and the epidemiology working with us. A big operation was to drive 7 hours to come here just to share with you our modest experience in that northern region and other regions around, like 5 regions are sending patients to our place. So the incidence is very high, not only in early age, it's early age and advanced stage, most of them here in this environment. The factors, many of them is multifactorial. We cannot say this is the key point that is developing in this. No, there are many factors. And maybe here we find some others, as you did, for example, in Nigeria. But each country has its own characteristics. I was working, for example, in Saudi Arabia for some time. Saudi Arabia, alcohol is forbidden. Pork is forbidden by law. And the incidence is very high. So you see, so each country has its own characteristics. So for it, we need, I think the cornerstone should be the screening programs. We need to go to the communities to look for it, to establish risk groups, taking into account the patients coming to us. But these patients coming to our facilities are the top of the iceberg. All the others are working. I was hearing the professor of the Ghana College. His history is very common. His mother, his brother, and I should tell him, and you are